Welcome to Health or Consequences, the public health and healthcare podcast series that runs under the Codcast label through Commonwealth Beacon. I'm Paul Hattis from the Lown Institute, here with my co-host John McDonough from the T.H. Chan Harvard School of Public Health. And today we're delighted to talk to Matt Veno, Executive Director of the Group Insurance Commission. Some of us know it often as by its initials GIC. Matt has been the Executive Director since March of 2020. And get this, listeners, I think he either started the job the week of or right after everybody was sent home from work for COVID. But in any event, Matt, we want to welcome you. We also like you to say a little bit, if you could, about the GIC for our audience, make sure they know what it is, as well as your own career evolution before you became the Executive Director.
Yeah, happy to. And thank you, Paul and John, for having me. An avid listener to the podcast and really delighted to be able to be part of it today. So the Group Insurance Commission is the state agency that provides insurance benefits to state employees, their dependents, state retirees, and then the employees of a wide number of other public entities in the state, cities and towns, regional school districts, housing authorities, education collaboratives. So we actually work with over 900 different public employers across the state. We cover 420,000 members, most of whom live in Massachusetts, of course, but we also have retirees that live across the country, across the globe in some cases. It does make us the largest purchaser of health insurance, employer purchaser of health insurance in the state. So that's a little bit about the GIC.
A little bit about yourself, Matt.
Yeah, sure. So I've been in and around healthcare and insurance and government for most of my career, sometimes inside government, sometimes outside of government. Most immediately before coming to this role at the GIC, I was first Deputy Commissioner of Insurance, so had 2 years or so from the regulatory perspective. But earlier in my career, had stops in human services, early education, a lot of social justice work actually as a younger professional, but always wanted to get into healthcare, so went back to school and get my master's, and then was employed at Harvard Pilgrim Healthcare, where I worked for 9 years doing government affairs at the state level for Massachusetts and New Hampshire, and also in Congress. It was a fascinating time. I joined there at the summer of 2009, so the few months leading up to the passage of the Affordable Care Act. So doing some really interesting work there. And it was from there that I ended up at the Division of Insurance. Also, just outside of that part of my career, very active in my community. I was a city councilor for 6 years in Salem, have served on a wide variety of local boards, and also been in and around the health center movement, community health centers, for a good portion of my career. Right now, I'm on the board of a health center on the North Shore. So that's a little about me.
This is John McDonough. Thank you for being with us. We really appreciate you making time to come and talk to our audience and us. So last month, the state legislature and the governor had to come up with $240 million to cover a fiscal year operating deficit for the fiscal year that ends this month. How did the GIC get into such a financially challenging position, and what happened?
Yeah, it's a great question, and this does it does happen on occasion. It's not the first time it's happened. It hasn't happened in a number of years, and certainly not to the scale of our funding need. But I'd start by saying that we were adequately funded in the state budget for this fiscal year that's about to end, based on our projections at the time. And so there are some timing issues that were unique here that led to this problem. But I'd say, we have long-standing trends that everyone is seeing in the healthcare marketplace now with rising costs to deliver medical services and prescription drugs. It won't surprise you to hear that one of the specific challenges this year was the introduction of the GLP-1 drugs for weight loss, that being Wegovy and Zepbound. But that's just one category. Cancer drugs, cell and gene therapies. There's a broad challenge with rising prescription drug costs. And on the medical side, medical services, just a sharp escalation of provider unit costs that have been really acute over the last couple of years. I'm sure we can talk a little bit more about that. But the timing issue is really what got us in this position this year. And it's the timing that relates to our rate development. So we make final decisions on our rates in February of each year for the coming fiscal year, which starts in July. And if you think about, so for our current fiscal year where we've had that budget shortfall, we were looking at data a year ago, February. And it was right at that time when GLP-1 usage for weight loss was just about to spike. And then, of course, we experienced that wave over the course of the last year. We've spent over $100 million on those drugs for a small subset of our membership. So that was a development that happened soon after we set our rates. And then I'd say the second factor here, again, timing-wise, is a lot of the contracts between health plans and providers have a January 1st effective date. So when you have rising prices that are baked into those new contracts, you don't start to see them until the early months of the year. So again, there were contract renewals that were done in January that we were only partially able to accommodate in our rates. So really more of a timing thing than anything, and it's not super unusual for us to need a supplemental funding.
So Matt, that begs the question of what are things looking like for the year that starts a few weeks from now, both in terms of the overall spending trend as well as what's happening with premiums for your members. What's going on there?
Yeah, well, I'll say the spending trends continue to be quite concerning. For our coverage that starts literally just in a few weeks on July 1st, we set those rates again back in February. We have an overall average for all of our plans, an increase of 11.7%, which is, we haven't seen these sorts of numbers in decades. Almost half of our members, including our Medicare members, are seeing increases that are less than 8%. So there's variation among all of our plans, but the larger increases are what we're seeing on our active employee plans. On the Medicare side, so we have a 7.3% increase on average for our Medicare plans. That's driven largely, I think, by some changes to the design of Medicare that were in the Inflation Reduction Act. My hope is that those will be one-time events, and some of the other changes to Medicare will bring that trend down. But on the active employee side, we're seeing the effects of general inflation roll through healthcare. We're seeing medical and prescription drug pricing inflation. We're also, those are long-standing, of course, the medical and prescription drug price inflation. But what we have often seen in the past is that utilization, particularly on the inpatient side, was going down, but that actually started to turn around over the last year or 18 months. We're actually starting to see some pretty significant increases in surgical surgical spend, inpatient and outpatient, for musculoskeletal, for cardiac conditions, and that sort of thing. So yeah, it's not a great time right now. We are adequately funded to meet the need as we see it now, but again, it's a super turbulent time, and it's just so hard to predict what spending trends will look like a year from now.
So this is John again. Let's talk a little bit more deeply on the pharma side, and particularly the GLP, the weight loss drug category. We know this is a national issue. There's been action in North Carolina, Connecticut, California. States are grappling with this thing the same everywhere. What's going to change or not change in terms of the GIC, and where do you put yourself in the national context of how other states are dealing with this and grappling with this huge challenge?
Yeah, well, first, I'd like to say that if it weren't for the pricing of these drugs, even net of rebates to a purchaser like us, if it weren't for that pricing, it would be an unmitigated celebration of these drugs. The clinical value, the improvement in health and well-being from those who benefit from them, but it's the pricing that really puts purchasers like us in a difficult spot. As you say, John, so many other insurance companies and state employee health plans are simply dropping coverage. We are maintaining coverage for GLP-1s, but we have made one change that will go into effect for our members on July 1st. We're using the traditional tools at our disposal, right? So we have a tight prior auth requirement for these drugs. And the change that we made was that we made a formulary change. So we're covering one of the two GLP-1 drugs, Wegovy, and dropping coverage for the alternative being Zepbound. And this is done with the express intent of just getting a better net price that we can sustain and continue to provide these to our members.
Is that similar to what's going on in other states? Or so some states are getting rid of it entirely. Are any other states leaving it wide open, or what are you seeing out there?
I haven't heard of any states that are leaving it wide open and untouched. We at the GIC, and I think a lot of employers, when these drugs first came out, we were covering them aligned with the FDA label. So a particular BMI threshold, a requirement that the member, before taking the drug, engage in some programs to manage lifestyle and activity and weight loss. But every state employee health plan that I'm aware of has had to tighten things up in one way or another. As you note, a larger number are just now not covering them. I think it's close to half of state employee health plans are not covering them entirely. Some states are doing what we're doing, which is trying to get a better net price by changing the formulary. But it's a rapidly evolving landscape.
And just one more thing on this. So you mentioned that there are health benefits associated with it beyond the weight loss or diabetes or whatever. What are those most significant health benefits that you see? And have you been able to measure any concrete dollar savings from those unexpectedly positive impacts?
We have not yet, because we're really only a year and a half or so into having those drugs available to our members. And for a significant part of even that time, there was a shortage of availability because of manufacturing challenges just to meet the need. So, I think the benefits from a financial perspective are likely to be long-term savings. But the health benefits beyond just weight loss, a number of the drugs, it's different for each of the two drugs, but one is approved for the treatment of obstructive sleep apnea. I think that's Wegovy, and Zepbound is approved for cardiovascular events. And we're expecting just a flood of other conditions that this drug, which really is quite impressive, could be used to treat. So yes, we do expect long-term benefits to our members, long-term reductions in the cost of healthcare services that they now will no longer need. But every study that I've looked at says that at the current price point, the spend will far outstrip the cost reduction in savings. It's not a cost-effective drug. It's effective, but it's not cost-effective.
Thanks for that, Matt. Let me turn to the provider side of the cost challenge for the moment. And we've all been reading, for example, last week in the small merge market, looks like the average price increase that the plan submitted was 13.4%, driven by the drugs, but also the provider spending. Our hospitals, if they were sitting here in this conversation, would say, look, last year, on average for the field, we had slightly negative operating margins at the median. Of course, there was variability there amongst the institutions. We're all sitting and waiting to find out what Congress is going to do potentially, and if there's going to be agreement on Medicaid cuts or cuts to subsidies to connector plans. All of that has revenue, let's say call it negative revenue implication for the hospitals. They've been getting, as I just noted, higher and higher rate increases and causing premium challenges to your members and others. Putting this all together, what's your take on what's going on and sort of what do we do?
I'm really worried about this moment, to be candid. It's a uniquely challenging moment in healthcare in Massachusetts. You and I, all three of us have been around these issues for a long time, certainly the two of you more than I, but what I see is two real colliding crises. We have, on the one hand, a healthcare delivery system that in many sectors, but not all, as you note, is under extreme pressure. We have broad access challenges for primary care and behavioral health. We have capacity problems in post-acute care, which clog up hospital inpatient beds. I would say, on the variability point, while on average hospitals have been losing money, aside from a few very well capitalized hospital systems, we have a wide swath of other hospitals that are under extreme financial pressures. And what's even more concerning there is that it's more frequently those that serve the most needy, including community hospitals, dish hospitals, community health centers. And now we have a federal government that is hostile to the policy priorities that we broadly share in this state. So you have that one challenge. Then you have rising premiums, rapidly rising premiums that I already spoke about, that are really just, we use the word unsustainable. We have been using it for healthcare costs as long as I've been doing it, for 15 years. But this feels like a whole different level of a challenge. When our costs go up 10% in a year, we spend an additional $300 million for the exact same product, insurance products to our members. Eats into wage growth for public workers, and that burden on the budget is, at this time, is just, it's a real problem. I wish I had a magic answer, but I do really worry about what this means for our ability to take on the real cost drivers.
So it appears, Matt, that on Beacon Hill, the priority issue they're focused on this year is primary care and behavioral health, but mostly primary care. There's a big task force that's hard at work to craft a proposal. Senator Cindy Friedman says it's her number one priority for this year. Are you looking forward to something happening? Do you have any idea what you would look forward to? And are there some outcomes from that process that you're very worried about seeing happen?
Yeah, so I'm like you. I'm really encouraged to hear the governor, the speaker, Senate President, Senator Friedman, and Chair Lawn and others really making this a priority for this legislative session. It really needs to be. The launch of the primary care task force is encouraging. We're following that closely, eager to see where it goes. But, there's, I don't know who issued the quote, but don't tell me what you value, show me your budget, and I'll tell you what you value. Our healthcare system does not value primary care. The dollars we spend there are a steadily declining share of our healthcare dollar. And we need to turn that ship around. I would say on this point, one of the core promises of payment reform is that it could and should provide the financial incentives to strengthen primary care. But this only works when the contracted dollars that goes to a provider system actually finds their way through that system and down to the delivery of primary care, to actually those who are doing primary care. We just have not seen that happen. So we have a rising cost burden, but a decreasing share is going to primary care. So yeah, can the GIC do things to ensure that those dollars get down to the primary care delivery level and actually change and strengthen care? I think there is. We certainly spent a lot of time thinking about how we might do that. I do think there's a role for innovation here. We've seen the introduction of virtual platforms, virtual first primary care. We see evolutions every day in the retail space with actors like CVS and others sort of building out this capability. I think we're going to need, all the innovation that we can get to really solve this access problem.
So it seems to me, Matt, you speak for the GIC and the 420,000 people whom you provide coverage for, but there's nothing in the issues that you talk about that aren't affecting the whole public. And so let me invoke the spirit of Dolores Mitchell, who was the iconic director of GIC in the 1980s and 90s when I was in the House of Representatives. And she was a force of nature. She would bang her fist on the table and tell off the hospitals, the physicians, the insurance companies, anybody who she felt like was not on the level in terms of what people needed and what needed to happen. Are you able to summon the spirit of Dolores yourself? Is that something you've been told, no, don't do that, don't go there? But because I find her kind of unforgettable, and just wondering how much her spirit still infuses the GIC as an organization.
Well, it certainly does, and I have great admiration and respect for Dolores. I did when I was an observer of her in the role that I now have, and I was more of a worker bee. And now I have even more respect for her, understanding the challenges that she had to deal with every day. She's unforgettable. I probably will be somewhat more forgettable in terms of my style. But I do, on occasion, and folks have heard this from me, I can summer my inner Dolores Mitchell when the time and moment calls for it. So, but yes, she's continues to be a beloved and deeply respected figure within the team.
And so just a final question for you. And again, thanks for sharing your time with us. Is there one thing in particular on the state policy agenda around healthcare and health services and medical care that you feel in particular really needs to be addressed in a serious way to improve the system for your members and for the public more generally?
Yeah, it's a great question. And I guess my plea would be to policymakers that they be bold. And as I say that, I understand how enormously hard it is to do that in this very uncertain environment. But we have a proud tradition, right, of bringing together coalitions to deliver high quality, accessible, affordable care. And that's really what this moment calls for. And I guess I go back, when at the time I first started at Harvard Pilgrim, the legislature was contemplating really the next stage of health reform beyond Chapter 58. And I think it was the passage of Chapter 288 of the Acts of 2010, where they really started to put the groundwork together for Chapter 224. But at the core of all of that work, of 224, was a commitment to maintaining healthcare spending in line with the rest of the economy. So this benchmark that people hear about is not just a feature or element of Chapter 224 that can be and should be adjusted and tweaked and changed. It is the core principle of Chapter 224, and it's a sound principle. And so, at the highest level, when it comes to policy, we have to start by grounding ourselves in that principle and not abandoning that principle. So through 224, we created this infrastructure of unbiased, reliable, objective data about what's happening in our healthcare system through CHIA. We created a data analytic capability and policy development, solutions development capability at the Health Policy Commission. They are pointing the way for us to address these challenges. They make policy recommendations every year. I'm really delighted that the legislature took up and passed in the last session some elements of that, but there's a lot more work that we need to do there. I think building on the tools, giving the HPC more tools that it needs around material cost change notices, the cost and market impact reports, the performance improvement plans. They are pleading for more tools, and we need to give them more tools. I think you said one, I'm going to give you two. I'll say lowering the administrative cost and complexity within the system, make it more efficient, save some costs, reduce member abrasion and friction. There are opportunities to do that. We can streamline prior authorization. I know the DOI is doing some work in that space, but we can do that.
So, Matt Veno, Executive Director of the Group Insurance Commission of Massachusetts, thank you for joining Paul and me today. Again, I'm John McDonough, and my co-host Paul Hattis and I thank you all for joining, and we'll be back again next month with another episode of Health or Consequences. Thanks, everybody, and thanks, Matt, and thanks, Paul.
Happy to be here.
Yes, thanks, Matt.